My name is Kirsten. I'm an undergrad student in theology, medical sciences, and sciences. I am doing my honors thesis with Johnson. The title of my study is Treatment of Chronic Illness Patients in Emergency Departments. My study is not complete yet, so today I will be going over what we've done and what we have to complete. Chronic diseases can be very complex and difficult to treat. This can lead to very fragmented care, and chronic illness patients tend to have traumatic medical experiences. In this study, we will be focusing on accessing healthcare in emergency departments. We will be learning the healthcare experiences of the chronic illness patients and determining ways to bridge the gap between chronic illness patients and medical providers. In doing so, we hope to improve the understanding and communication between patients and providers. This should lead to more efficient and successful emergency department visits, as well as build a better rapport between patients and providers. So far, we have completed a literature review. That was difficult to do as there's not a lot of research on chronic illness patients accessing healthcare. We have also developed a study design, and we are in the process of submitting the IRB. Once we get IRB approval, we will be approving chronic illness patients, and we will conduct 22 focus groups. So we will summarize the data, and then we will design an infographic.
Hello, I'm Audrey Bierman. I'm a senior here at the U of A studying neuroscience and cognitive science, and I'm one of the certificate in developmental disabilities students. So for my certificate, I completed research with Dr. Julie Arman. Dr. Arman led a team alongside Dr. Heather Williamson at Northern Arizona University to create a continued medical education course for current healthcare providers, educating them on how to best work with individuals with developmental disabilities. So this course was made in response to surveys sent out to current medical care providers, asking them to rate their current competency and confidence in working with people with developmental disabilities, and they found that they weren't confident or felt that they were competent to work with this population. So they decided to create a continuing medical education course to help bridge this gap of knowledge and help them best serve their patients. So this continuing medical education course had 3 modules. The first was accessibility and equity, which talked about different accessibility measures that healthcare professionals could implement into their practice to make it both more physically accessible and make the information more accessible. Module 2 talked about consent and decision-making. Module 3 talked about supported decision-making in the clinical context, with a specific example of the flu vaccination and how that can be discussed with their patients and how best to get consent with that. So participants in the CME course completed several surveys as part of their participation. First, they did a demographic survey, then, which can be seen in table 1. Then they completed a pre-quiz where they completed a quiz that helped assess their current level of knowledge on working with people with intellectual and developmental disabilities. Then they completed the course. Then they did a post-quiz, which asked the exact same questions to determine how their knowledge level changed as a result of completing the course. Then they completed a satisfaction survey where they self-reported how they felt their knowledge had changed on the 3 learning outcomes. And they were also asked an open-ended question about which practice changes they plan to make in response to the knowledge that they gained from the course. And then 30 days after they completed the CME, they were asked to complete another survey talking about the actual changes that they had made in the last 30 days since they completed the course. So my job when I came in is to take all the data from the different surveys that they completed to create a comprehensive picture about how successful the course was. So for the pre and post quiz, this is in table 1, we can see that their responses, they were more correct for all of the questions in the post quiz and the pre quiz, with the exception of question 2, but that's just because they all got it correct the first time. So they kept that knowledge and got it all correct the second time as well. In the satisfaction survey, for all 3 of the learning outcomes for the CME course, we saw that 90% approximately self-reported that they had increased in knowledge in those learning outcomes. And then in the free response section, when they were asked to talk about different practice changes that they think that they will make in response to taking the course. Some examples of what they said were one person stated that they would promote supported decision-making for people who need help making healthcare decisions. Another person said that they would ask patients prior to visits about use of mobility devices and questions about guardianship. And then a third person stated that they would provide accessible spaces, incorporate education about choices in plain language, and ensure that guardians are well informed, so that those with IDD are equally informed and protected. These are just some examples of things that people stated, but they also exemplify some themes that we're seeing in many people's responses. One example is for figure 2 shows one of the questions we asked in the 30-day follow-up, where we asked about the practice changes and we gave some examples of changes that they might have made in the last 30 days. For each participant, they at least made one of the changes, and they also, for all of the proposed changes, at least one person said that they had made them. So from all the data we collected, we saw that there's both a quantitative change of knowledge seen in the pre and post quiz results. There's also qualitative change in the self-reported knowledge that they felt they had on the topic. And we also saw concrete practice changes being made as a result of people completing the course. It was very successful. That's all. Thank you.
Well, hi, everyone. My name is Madison Krager, and I'm a senior in the Pharmaceutical Sciences program, and I'm a Disability Policy Fellow. So for my project, I chose to focus on the inequities and post-operative outcomes for individuals with intellectual and developmental disabilities. What I found in the literature is that after undergoing surgery, people with an IDD have been found to have increased rates of surgical complications like pneumonia, septicemia, acute renal failure, and post-operative bleeding. They often present with a more progressed disease state. There's an increased rate of mortality. They often have longer hospital stays, higher rates of non-routine discharge, and higher inpatient costs. So unfortunately, there's a lack of research in the causes of these disparate outcomes and a lack of policy at all levels to address these issues. So for my policy analysis, I conducted a thorough literature analysis on the postoperative outcomes, explored available policies at hospitals, medical organizations, and at the state and nationwide level, and conducted interviews with stakeholders. So some of the identified issues that may be contributing to these outcomes is a lack of research in the area and a lack of medical professional and public awareness on the current disparities for people with IDD after surgery. There's also a lack of IDD specific training for all medical professionals. Currently, there's 7.4 million Americans that have an IDD, but there's no specific IDD curriculum that must be taught at all medical schools or residencies. There is a national curriculum initiative in developmental medicine that offers grants and resources to schools to expand their IDD curriculum, but only 15% of medical schools are taking advantage of this at this time. The U of A is one of them. There's also negative medical professional perceptions of disability, and there was a survey done of U.S. physicians that found that 82.4% of physicians believe that people with a significant disability had a worse quality of life than non-disabled people, and only 40.7% of physicians felt very confident in their ability to provide equal care to people with disabilities, and only 56.5% of physicians said that they strongly agreed that they would welcome disabled patients to their practice. Another issue identified was that the understaffing in hospitals and long-term care facilities. There's no nationwide policies mandating nurse-to-patient ratios and no enhanced ratios for patients with disabilities. So the recommended nurse staffing is 1:4, and research in this area has shown with those ratios, there's increased patient outcomes and lower mortality. There's also difficulties for physicians in diagnosing patients with IDD, since they can present with differing symptoms, and they also have difficulty communicating their symptoms. There's often a lack of transitional planning from the patient to the care at home, and there's also a general inaccessibility of clinics and diagnostic procedures for people with IDD, and there's difficulties getting appointments with specialists. So in light of these findings in my project, a multifaceted policy approach would be needed. I propose continued research and funding on IDD and surgical outcomes and investigating the underlying causes. There would need to be strong disability advocacy to hospitals and organizations like the AAMC and JCO to improve IDD training. And there should be nationwide policies on hospital staffing and long-term care facilities with enforcement and oversight. And there should be adjustments to the diagnostic differentials based on how IDD presents. And there should be required surgical and post-operative precautions for vulnerable populations that are more susceptible to complications. Thank you, guys.
Hi guys, my name's Isha Mather. I am currently a junior here.
I'm Freya. I'm a senior in neuroscience and cognitive science.
So we're really excited to be here today to talk a little bit about our research. We were looking at understanding policies that affect cancer care access for individuals with intellectual and developmental disabilities. So just for a little bit of context and background, there are national policies like the CDC Breast and Cervical Cancer Early Detection and Treatment Program, which is responsible for promoting cancer care awareness, early detection and treatment for individuals across the nation. So that's a really exciting program. But there's also state health policies that are responsible for cancer care awareness, detection, and treatment. And it's these state policies that are really influential and important to the IDD community. Two other policies that are really important are Medicare and Medicaid. Medicare eligibility is based on, for Medicare, it's your disability status, and for Medicaid, it's things like your financial status. And usually individuals in the IDD community are dually eligible. So these programs are super important, and it's up to really the state and the state health policies to support the benefits and services that come with being eligible for Medicaid and Medicare. So really, it is the state that influences healthcare access for individuals with disabilities. So when you look at your state, it's really important to understand whether or not your state is Medicaid expanded or unexpanded, because that can change who in the IDD population is actually eligible. If you live in a Medicaid expanded state like Kentucky, which is the state that we studied, then there's a larger population of people that are eligible for the services that Medicaid provides. But if you live in an unexpanded state, the population of people that are eligible for Medicaid services and the cancer care access that can come with it is a little bit smaller. So a state like, for example, that's unexpanded would be Georgia.
We became interested in looking at these differences due to the results we found from a data set where we looked at the survival rates and outcomes for people with IDD and colorectal cancer. And so we found Dr. Armin and the team earlier on in the study found when controlling for comorbidities, when controlling for age and sex and other characteristics, people with IDD had worse outcomes with cancer compared to the general population. And this was even when they were diagnosed earlier. So our team hypothesizes that this difference is due to policies that relate to the social determinants of healthcare and how people with IDD are experiencing them. The social determinants of healthcare can be summarized, as we've done, into 5 different areas. They include education, someone's personal access to education, the education that they're surrounded by in their communities. This also relates to their economic stability, which furthers their sense of independence, their access to opportunities. This also relates to their community context, the support that they receive from social systems, as well as their own personal support networks, as well as their physical environments, which contribute a lot to someone's overall access to opportunities in their region. And of course, healthcare.
Yes, so with Freya kind of explaining our project and the reasoning for our project, I think we can move to table 1, which explains our methods and how we decided to kind of tackle our question about individuals with IDD who have higher mortality rates when it comes to cancer. So first, kind of like Freya explained, we had the pre-stage where we analyzed SEER Medicare data that included the unexpanded state of Georgia and the expanded state of Kentucky. And we found this really shocking kind of conclusion. And that's kind of what prompted our research project. So then we moved into stage 1, which was policy surveillance of Georgia and Kentucky. So we looked at their state policies, their programs, and their waivers to get a better understanding of the services and benefits that they offer for individuals in the IDD community when it comes to healthcare access and cancer care access.
We also conducted policy surveillance of federal legislation when it comes to the IDD population, just to get a better understanding of how state policies compare to federal policies. So that was stage one. And then we moved on to stage two, which I think me and Freya found super insightful. We got to actually conduct in-depth interviews with local disability experts in both Georgia and Kentucky. And we got some insight into how the policies we just learned about were actually being implemented in the community, which was, again, super insightful. And now we're in stage three, which is actually getting to collaborate with these local disability experts to create a narrative style policy brief, which is going to kind of combine the work we did with policy surveillance with the in-depth interview information that we learned to create a brief that really explains what services are there and how the services are being implemented. So to go to table two, these are kind of the results that we got from stage one, our policy surveillance. So our first step was to look at the state policies in Georgia and Kentucky that were classified as health policies. So in Georgia, there was about 260, and then in Kentucky, there was about 89. But then when we read through all of them, we found that in Georgia, around 20, I think that I can't really read it, but 20-ish policies were considered relevant, whereas in Kentucky, about 66 were considered relevant to our study. So that means it concerned the IDD community, cancer care access, healthcare access, the social determinants of health, things like that. And then we did a further analysis. We broke it down further. We took these relevant health policies that we found, and we determined the number of significant policy keywords which were actually in these health policies. So the first couple keywords are pretty self-explanatory: cancer, disability, healthcare access. These are all really important words for our study, which concerns the IDD population, cancer access, healthcare access, things like that. And then the other words like facility, assistance, case management, transportation, all were words that really apply to the individual and how they're receiving their healthcare access, especially because a lot of these words like case management, transportation, and treatment really tie into the social determinants of health.
As Isha was saying, these more specific keywords not only tie into the social determinants of health, but they also specifically target our population. We find that there's a lot of work done on individuals that are physically disabled or at least flagged in that way. But since we are specifically looking on people, looking at the population of individuals with intellectual and developmental disabilities, we wanted to see which policies might also affect them because they might not always come up under a general disability term. What we've also started to do, as you can see in table 3, is we've looked at the Medicaid policies. So these were the policies that we had for Kentucky and Georgia, and each state has their own. And we started to code them by the social determinants of health. This is something that we're going to continue to do as we develop our policy briefs, because those are going to be specific to each state, because each state has their own programs that they have structured to serve their people in a certain way. Overall, in our other results, as we mentioned before, our stakeholder meetings were really important for us to start to understand the barriers to healthcare in both Kentucky and Georgia. When we were talking to these experts, things like rurality, things like transportation and provider education did come up in different ways. And we were able to apply these themes and look for these themes as we continued with our policy surveillance.
Yeah, so then to go back to table 2, just to summarize our results, we found that at the top table of table 2, only a few of Georgia's policies were actually considered relevant out of the 260. And this was because Georgia's health policies were categorized in a way that each policy concerned a very specific population or a very specific topic. So only a few were actually relevant to our study, which was something very interesting, because when we looked at Kentucky's health policies, they were a little bit more vague and considered different populations in each health policy, which was very interesting. For the second table, we found that Kentucky's relevant health policies actually had more of the significant policy keywords that we were looking for than Georgia's, which again is something interesting when you consider that Kentucky is an expanded state and Georgia is unexpanded.
As to an update on our policy briefs, we continue to work with local experts on these because while we are looking at the policies on paper, it's also important for us to understand how they're functioning on the ground. So things like the wait list to get IDD services in a state or the capacity that is unfortunately limited in states for providing people these services can imply how these policies play out. For example, when we looked at a program in Kentucky that was intended to provide all-inclusive care for the elderly, when we look at what regions of Kentucky actually have providers that qualify with this program, we'll find gaps there in what people can currently access. And while things are constantly improving, we intend to summarize things as they are in terms of how policies in cancer care relate to people with IDD in these policy briefs, which can then be published and sent out to relevant experts and researchers for further work.
Yes. So to kind of go off of what Freya said, our next steps is to kind of finish our Georgia and Kentucky narrative style policy briefs with our local disability experts, and then hopefully publish so that we can spread awareness and just, try to improve healthcare access for the IDD community.
Hello, everyone. My name is Jenna. I am a senior here at the U of A, and I am studying public health with an emphasis in health promotion.
My name is Victoria Almanza. I am also a senior studying public health with an emphasis in health promotion. And we will be talking about making vaccines accessible for the intellectual and/or developmental disability community. The disability community experiences a deficit in vaccinations due to a lack of awareness and access to vaccine resources. The Sonoran Center has a vaccine project that aims to increase vaccine awareness, enhance accessibility, and reach diverse populations.
So for the project, the Sonoran Center's roles were to collaborate with organizations to host vaccine events, provide accommodations such as interpreters, private spaces, and accessible entrances, and most importantly, offer vaccinations such as COVID-19 and influenza.
So you can see we created 2 tables. Sorry.
And then, sorry about that. And then Victoria and I's roles for the project were that we use social media as an educational tool to inform the public on why people should get vaccinated. We posted updates on vaccine events happening, and we collected data from each vaccine event we held and organized materials.
As you can see, we created 2 tables to broadcast the results from the vaccine project. The first table shows how many individuals were reached through outreach and engagement. For example, we advertised the vaccine events through social media. From the Accessible Vaccine Clinic event, we were able to reach 460 individuals. The Circle of Indigenous Empowerment, Disability Inclusion Training Vaccine Clinic, there was no data for outreach. From the Nogales Disability Resource and Health Fair, we reached 781 individuals. And from the Indigenous Peoples Day, 3,700 individuals were reached. The second table shows the number of vaccines that were administered at each event. Some of these vaccines, like we said, were COVID-19 and the flu vaccine. At the Accessible Vaccine Clinic event, 5 vaccines were administered. At the Circle of Indigenous Empowerment, Disability Inclusion Training Vaccine Clinic, 15 vaccines were administered. At the Nogales Disability Resource and Health Fair, 17 vaccines were administered. And finally, at the Indigenous Peoples Day, 10 vaccines were administered. Now, you might assume there would be a correlation between outreach engagement and vaccines administered, but really we didn't see any pattern there. However, it is just as important that people are being educated on the significance of vaccines, regardless of them attending the vaccine events and/or receiving them.
Okay, so in conclusion, we saw that participation in vaccine events led to people getting vaccinated. It also increased communities' knowledge about the significance of vaccinations. And not only were these vaccine events crucial to vaccination resources and awareness, additional information and referral to supportive services were provided to further benefit the community and their health in the future. As Victoria talked about, we were able to get documentation and reports from each event, which ultimately helped us get feedback for future events. So why is this important? We believe the vaccine project is important because vaccine awareness and accessibility is essential. Ensuring that vaccine information is accessible to the IDD community is a huge step towards inclusivity and healthcare access for all. Thank you.
Hi, I'm Alexia. I'm majoring in public health and I'm a senior here at the University of Arizona. So I did my poster on assessing the gaps of family planning for people with intellectual and or developmental disabilities. I found that there is an inadequate amount of accessible family planning healthcare information available for individuals with IDD. And resources need to be accessible to ensure equitable reproductive treatment. So growing a family is a goal for many people, including those with intellectual and or developmental disabilities. And planning is a great step to ensure that there is safe reproduction and childcare, as well as establishing postpartum care. So I attended many healthcare webinars and seminars, as well as volunteered at the Pregnancy and Planning Forum in the same day as having a discussion at the Community Advisory Council meeting. I used survey data from the pregnancy and planning experiences of people with disabilities project and conducted my own research on family planning education availability. So I found through my research that there was a lack of best practices training for healthcare providers, as well as limited accessible family planning reproductive healthcare curriculums and barriers to contraception for individuals with IED, including access, education, and cost. So I made a Venn diagram addressing the barriers from the pregnancy and planning experiences of people with disabilities project survey. On the right side, I have some of the main patient points, which included a lack of information on breastfeeding and caring for a baby with a disability, limited accessibility to adaptive childcare, resources on paperwork needed for the baby, and baby care skills. The providers addressed a lack of information on types of disabilities, limited appointment times, which could be due to insurance purposes, and lack of appropriate equipment and transportation. Both the patient and the providers found that accessible buildings and exam rooms were inadequate. So part of the discussion that I had at the council advisory meeting was, where can somebody with IDD discover accessible resources easily? It seems that much of the information out there is not accessible and does not address individuals, either parents nor children, with IDD. And through discussion, I found that helpful resources would be parenting groups, printed paperwork, and social services. To bridge the gap for the IED community and family planning, there's a need for a new policy on requiring healthcare best practices training for providers and a one-stop forum, including resources and recommendations for parents with disabilities and or parents who have children with disabilities would be beneficial to the community. Thank you.
All right. All right, so one, we want to thank you all for hanging in there because we went longer than we anticipated. And we are at 6 o'clock now, but I hope that you'll stick around and still take a look at all of the posters that are here. And we just want to acknowledge all of our faculty and staff mentors, our community partners, and all of the staff here at the Sonoran Center who really helped to support all of our students this year, so that they could do a lot of the amazing work that they shared here today. And also, if we'd love your feedback, how we can improve this event for next year, as well as how you can stay connected with all of us in the work that's happening at the Sonoran Center. If you have any questions about our programs, feel free to reach out to Selena. And please check out the Padlet. All of the posters are also available there. They're accessible to screen readers and have all of the information. I noticed there's still some lost in translation between computers. I don't know what happens when everything looked fine this morning. But we appreciate you all coming today, and thank you to all of our students. You all did a great job. Okay.